So welcome. This is, I believe it's our 9th patient seminar. Today is going to be especially interesting. We have, we'll start with the housekeeping items. So please keep your video off and stay muted. If you have questions or comments, please put them in the chat. This is not meant to be medical advice, as usual, and we can move on to the next slide. This seminar is in memory of Aaron Bowers, May 1958 to December 2017. Aaron was nominated to be remembered by Claudia Mokowski. Aaron was a nurse practitioner, certified in adult geriatrics as well as palliative care, and she was apparently, from what Claudia said, a wonderful advocate who spoke to many people during their treatments. Okay. All right, so I'd like to introduce our speaker, Merv Travers. He called this pain, it isn't in your body, it's not in your head either, but I wanted to call it pain down under. Because he's coming to us from Australia, so from Perth. So it's 10 a.m. in the morning there. I'm sorry for the odd time of the day, but we are an international organization, so we do our best to include everyone. So welcome.
So look, thank you very much for the opportunity to present to your group. It's always nice to be invited, and yeah, as you say, Perth is a geographical anomaly. It's a million miles from everywhere in the universe, and so lining up time zones with Perth and even places within Australia is a problem, let alone internationally. So recognizing it's an odd time of the day for us all. So look, my name's Merv Travers. I'm a physio by training, is my background, or I think you'd call it physical therapist. But I've been working for many years in research as well as in clinical practice. And my area of interest in research is to do with exercise rehabilitation for persisting or chronic pain. So pain that's been going on for a long time. And so I'm in this kind of very privileged position that I get to both see patients, but I also get to kind of work in universities and teach our healthcare professionals on these topics. And I get to kind of fly around the world and speak to various people about it. So I recognize it's a privileged position to be in. Just a few acknowledgements, of course, when I'm going to talk about some ideas. I might even mention some research we've done as a group. It's always important for me to acknowledge my colleagues. They say in life, you become the mean of those you surround yourself with, and if that's the case, I've surrounded myself with very good company, and I'm the one holding on to their coattails, holding them back. So I'm always very grateful for everything I've learned from my colleagues. Just as a starting point, I think, you know, pain is a really interesting topic. It's a complex topic. It's something we don't fully understand, despite how universal it is. You know, we all experience pain of various different forms at some point in our life. We would think we would kind of know lots about it, but it is quite a nebulous thing. And just sharing with you what spawned my interest really in this field over 20 years ago, when I was training to be a physical therapist or physio. I was also a rugby player at the time, and I remember playing. This is a picture of rugby if you don't know the game, and it's a rather brutal sport. Think of it like NFL, but without all the pads and helmets. And you know, I would occasionally have to tackle people, which means putting your head in the spokes. And I remember playing in a game, a cup final back home, and I woke up the next morning and I thought to myself, my teeth feel strange. And so I was lying in bed and I was kind of probing my teeth with my tongue, wondering what's happened. Have I knocked a tooth loose? Is there something not right? I went to the mirror. I'm playing with my teeth to see if something has been knocked loose. I can't make sense of it. So I called up my dentist and I went to see my dentist and I said, look, something's not quite right. And they were looking and checking all my teeth and everything was fine. And they were saying, look, did you get hit in the face or anything else? I said, well, I played a big game. There was lots of tackling, so I got hit in the face lots of times, but nothing unusual. And then I realized while I was sitting in the chair, I said, Joe, I think I know what's right. What's wrong? My bite doesn't quite line up. I said, it feels like my bottom teeth and my top teeth, I think they're not quite lining up. And the doctor took a mold of my teeth and said, yeah, that looks about right. And then they took an x-ray of my mouth. And in that x-ray, they happened to find a fracture of my jaw. And so they sent me to the hospital to go and have that looked at. And when they went and did some more extensive x-rays and pictures in the hospital, it turns out I'd a broken two vertebrae in my neck as well. And it was always amazing to me, so this is me very early in my career. I wasn't qualified yet. It was amazing to me, this idea that I could have done that much damage, but didn't have any pain at all. And then I went out into clinical practice as a physio, and I used to see lots of patients who had things like joint replacements done. And whilst knee replacements are extraordinarily helpful for an awful lot of people, I used to see some patients who've had their knee or their hip replaced, and yet they still had the original pain they had. And I thought to myself, how can that pain be coming from the tissues in their knee if that knee has been removed and it's been put in an incinerator months ago and they've healed up from their surgery, but they're reporting the same pain they had prior to the knee joint replacement. And I suppose that really spawned my thinking and my line of inquiry over the last couple of decades, I suppose. And so I always start my presentations with this slide, and it's a quote that's ironically attributed to excuse me, a quote that's ironically attributed to Mark Twain, who there's no evidence that Mark Twain ever wrote it, but it says, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." And the reason why I start with this slide is I don't have all the answers. I don't know everything. We're certainly trying hard to figure out and answer some questions. And I think, so many of us will seek care for various different forms of pain. And, we might not get the answers we want or the result that we're looking for. But I think we have to recognize that it all comes from a place of love, a place of trying to do good for people. But we just don't know it all. And if something I say conflicts with something you've been said or something you've heard, something you've read, that's okay. There are different opinions, different voices in this space, and I'm very happy for us to trash out these different opinions in our kind of question and answers. Finally, just a caveat before we get into the presentation proper, that this presentation, of course, isn't intended as a form of medical advice or healthcare advice. And so, please don't infer anything from what I say as being kind of specific advice for you or how you should consider a diagnosis or treatment or anything like that. So let's have a rundown of what our next kind of, I don't know, 40, 45 minutes together looks like. I want to start us talking just very briefly about back pain. The reason why I'm focusing on back pain here is, look, back pain is one of the largest healthcare burdens in the world in terms of both economic cost and personal cost to people who have back pain. For example, in Australia alone, the cost of chronic pain is about 70 billion to the economy a year. About 45 billion of that comes from lost productivity, so people being unable to work. And so it's a really, really big problem. But it's where my area of interest is, largely where I do a lot of my research. So it's kind of, if you will, my safe space to talk about. Um, then I want to get into this idea that pain isn't in your head and it's not in your tissues either, which can be a kind of strange kind of thought to have as a patient, because if your back hurts, you assume it's because there's something damaged in my back, of course. And then equally, the most invalidating thing you could hear is the idea that someone says your pain is all in your head, which is just not true, of course. And so we can glean a lot from what we understand about other conscious experiences. So I want us to take a deep dive into the idea of conscious experiences and then apply that to pain. So that's what we're going to do in our next section, which is the inferred nature of conscious experiences. And then we're going to talk about emerging treatments, because the last 2 years have actually in this space been pretty revolutionary. There's now data suggesting effective treatments that can reduce pain and reduce disability from back pain and other types of pain, which did not exist before and have produced long-lasting, sustained effects on groups of patients who previously we've had no success treating. So there's really forward momentum in this space. So let's start. Let's talk about back pain. And so just to kind of get us started, this is, I'm a data guy, so we're going to show you some data. There'll be some stories on the way, but I'm going to show you some data. If you're not a data person, that's cool. I'll try and make clear the message about the numbers as I'm talking anyway. But the idea or this data here comes from a study that was done in Sydney about 15 years ago, where about 1,200 patients who were turning up to either their doctor, their family doctor, their physical therapist, or their chiropractor, or their osteopath, or whomever. They were attending for kind of primary care for an acute episode of low back pain. And what these researchers wanted to look at is, like, of these nearly 1,200 people, how many of these people have something seriously sinister going on in their spine? And what we mean by seriously sinister is, the presence of, an osteosarcoma or some kind of cancer or tumor there, the presence of an infection, having a neurological deficit of what's called cauda equina syndrome, but damage the lower levels of their spinal cord, an inflammatory disorder like rheumatoid arthritis, or a spinal fracture. And as you can see, it's less, and any time when someone has an acute episode of low back pain, it's less than 1% of the time that it's something very sinister and serious that's driving it, even though it can be very, very painful. Now, the important thing is that's not that we disregard and say, well, it's most likely not something sinister. Of course, these things need to be ruled out, to make sure they're not there, because the consequences of each of these is very significant. But it is reassuring in some ways that it is most likely that an episode of low back pain is not caused by something very serious. Having said that, if someone had a history of cancer, that raises, for me, I'm going, okay, I need to rule out that there isn't an issue there. Okay, if someone has had a fall or is osteoporotic, I need to rule out there isn't a spinal fracture there. So they aren't. It's not a throwaway statement to say it's usually not serious. It's a great thing. It's usually not serious, but the first step is ensuring that it's not. Okay, so ruling those things out, and so the prevalence is very low. But what ends up happening then is all of this kind of, if you will, kind of yellow section here, we gets labeled as non-specific low back pain. And what we mean by non-specific low back pain is, look, we're very happy it's not a fracture or a tumor or damage to your spinal cord or something very, very serious like that. But we don't really have any good tests to tell you what tissues are offending. Now, the good news is, if you look at, this is some data from a research project we've just published, and we tracked the data from about 20,000 patients who had low back pain, and they were followed over time. And so this, if I bring your attention to the graph on the top left corner, the vertical axis is their pain score out of 100. So what we're saying here is most people in an episode of low back pain, they have reasonably moderate to high pain levels, and that drops reasonably substantially in the first few weeks. So in the first few weeks, your odds of recovery are very favorable. Most people get better, and the drop in pain is pretty substantial in the first few weeks, independent of what type of care that you get. So that's a good thing. But I'm going to bring the story full circle to this at the end, but I need to flag to your attention here that when people have had pain for at least 3 months, and we call that persisting pain or chronic pain, but the idea that the pain has been going on for a long time, then if you follow those people over time, their odds of recovery is much less strong. And traditionally, we found it very hard to help these people. We've found it very hard to find solutions for people who've had pain for a long time. In this example, back pain, until, as I said, at the end, we'll talk about some newer treatments. But that's just kind of setting the scene about back pain. This is the space that we're kind of talking about here. But I want to talk about why pain maybe isn't in your head and it's not in your tissues either. And it's probably an emergence of something in between. And so I mentioned before that my kind of passion in my area is for exercise, for low back pain. And so, for example, I know it's a slide with lots of fancy kind of words that sound like they come from Harry Potter or something, but these are different mechanisms that scientists suggest, hey, if you do exercise, this is why it's helpful for you if you have pain. For example, there's systems that dampen down the level of what we call nociception, and nociception is your sensory systems detecting damage in your body. So it seems like exercise has the ability to dampen down your system's sensitivity to messages regarding damage, for example. It can promote tissue healing, it can optimize your immune system. So it has some benefits, or at least theoretical benefits, and benefits that we've shown certainly when we do studies on animals. But this whole idea is based on this premise, okay? This premise that if I look here on the right-hand side of the screen, this is a diagram of your central nervous system. And so down here is meant to be a slice through the spinal cord, coming up through the midbrain, up to your brain. And the idea here is, the only thing I want to take from this is there are pathways, there are specific and known pathways where messages are passed through your nervous system that relate to damage, and there are pathways that allow us to turn those messages down. That's really what I want you to get from this. And one of the ideas is that exercise can induce these positive changes, we think. But having said that, one of the ways we measure the effect, or this phenomenon that exercise can make your system less sensitive, is we basically press on people with a probe. And after a while, if you press on someone hard enough, eventually that becomes a little bit noxious. You don't like it. And then they press a switch to stop it. And we measure, okay, well, it took this much pressure for that person to say that's become painful. And then we get them to do some exercise. And then we do that same probe test again on the same area. And usually, then we have to press much harder the second time around to cause them pain. So, okay, the exercise has made them less sensitive. So the idea is you press on somebody, you give them exercise, the next time you press them, their system is less sensitive. But one of my colleagues over in Denmark did a study a few years ago where he was trying to understand, well, what's the mechanism? How does this work? And he did a study where he got two groups of people, and he told one group, you know, exercise is, it's kind of damaging for your muscles. When you exercise, you get a little bit muscle sore, et cetera, et cetera. And he told another group, well, exercise is good. It releases endorphins. You feel good, et cetera. So the two groups did everything the same, except they were given different advice. And it turns out that this reduction in sensitivity that we see after exercise, which is called exercise-induced hypoalgesia, it turns out that the magnitude and direction of that change was determined by what the people expected. So if they expected exercise to be harmful in some way, they became more sensitive rather than less sensitive. And so it would appear that what we've always thought about, exercise changing things in your tissues, for example, maybe it's actually more about how people expect there to be positive or negative change, their previous experiences about exercise, their thoughts, their beliefs about it. Maybe their expectations are more important than what's happening at a tissue level. To give an example of this is a project that I was part of. It was a small kind of proof of concept study. We're just playing with an idea, and there's been more work done since. But we got some runners who had a painful Achilles when they were running, and particularly hurt when they hopped up and down, and they'd been sore for quite a while. And what we did was, all of our treatments in the past have always been about, rubbing their Achilles or strengthening their Achilles or doing something to the body tissues. We said, we wonder what happens if we get these people to look at images of feet or images of hands. Okay. But they weren't just looking at the images. The images look like this, and they have to orient, is it a left or right image? So in your mind, I'm going to show you an image of a foot now. You don't have to say it out loud on camera, I think, but just tell me, or tell yourself, is this a left or a right foot? Again, tell yourself, is this a left or a right foot? And so we got the people to do 20 minutes of this, playing with these cards and these images where they had to determine what side it was. So the key thing about this treatment was they're using the parts of their brain that you use for planning movement, for hopping, running, etc. But they're most certainly not using the muscles and the tendons, etc. And the control condition was compared against doing the same thing with pictures of hands. And what we found was a substantial drop in pain when people did this task just playing with images, okay, of feet, not using their body at all. And so we're thinking, okay, maybe their pain, maybe the resolution of their pain isn't all about the tendon. Maybe there's some other things going on, that the pain we have is in part what's happening in the tissues, but also in part how your central nervous system, how your brain kind of manages and deals with and processes all of the information coming into it at any one time. To give an example of kind of disentangling this idea of messages in your nervous system relating to damage or nociception and the experience of pain. There was a really important study done in the Netherlands a few years ago, and they got people with various different types of low back pain. And they did all sorts of very fancy clinic or very fancy tests, the types of tests that are very hard to obtain in clinical practice, but are used for research purposes to try and they try to identify of these hundreds and hundreds of patients with back pain, what the offending tissue was. And they were able to say some people, it was their facet joints. For some people, it was their sacroiliac joints. And for some people, it was a combination of various different tissues. But they did some very precise work to kind of find that out, gold standard work. And so then what they did was they randomized those people into two different groups. Everyone did exercise, but one group also had a treatment that's called radio frequency denervation. And so radio frequency denervation is a way of ablating or effectively burning away the local sensory nerves in those tissues. So if those tissues can no longer transmit information regarding to damage, then your brain and your central nervous system should no longer be interpreting like threat or damage, danger, and there shouldn't necessarily be any pain. That's the whole rationale behind that treatment. But when they did this, and applied this treatment, it didn't improve those people. Okay, so taking away the messages from the tissues about damage did not make any clinical improvement for these people. Okay, so they're no better having taken that away. And that led a couple of my colleagues to write a really important paper, I thought, where they suggest like this paper, this finding, it's a line in the sand. We have to kind of move away from thinking about, you know, back pain as an example here, but pain in various parts of the body as being just about damage, and trying to treat that damage or treat those tissues doesn't seem to be really winning the war against pain here for us. We have to consider that low back pain and other forms of pain, they come from multiple interacting domains. So if I was to summarize this, sure, we have a nervous system, and that nervous system is very, very good at transmitting information to our brain about and processing information from our tissues about damage, danger, and threat. And we've known pathways and systems within there where we know that we can dampen down some of that messaging a little bit. But treatments that are based on trying to, in some ways, block that messaging here or block that messaging up in the brain, for example, have really fallen short and not provided a great solution for an awful lot of people. And I think part of the problem is we need to step back and take a wider view. Okay, because if we're focusing in on these schematics and these diagrams and and just the nervous system, we ignore the fact that this person, this patient who has pain, this person who's experiencing pain is more than just a brain and a nervous system. They're more than just discs and nerves. Okay. They are a whole person. They have a body and a brain which are inseparable. And they too are inseparable from their wider world. Maybe we need to take a view of pain and take a perspective at this problem that incorporates all of this, incorporates the wider person and their connection to the wider world and all of those interacting domains when it comes to pain. So that moves me on to the next section, which is about where we can have some fun. Okay, this is about the inferred nature of our conscious experiences. What was really interesting for me over the years is, pain is a conscious experience. We all have it, but so is taste, so is hearing, so is smell. So there's so many of these. And I started looking more widely, saying, okay, well, what can we take from what we know from these other senses and other conscious experiences and see, can that inform our thinking on back pain or other forms of pain and what we can do about it? And so what I want us to do is take for about 5, 10 minutes, a bit of a deep dive into this kind of area of pain or excuse me, the inferred natures of our conscious experience. And what I mean by inferred is this. We never truly taste what we eat. Because when we put something in our mouth, we chew it, there's chemicals that are detected on our tongue, and then there's electrical signals that are sent and chemical messages as well that are sent from our mouth and into our brain. And there's information coming from our nose as well, because the olfactory system, what we smell, also informs about what we're eating. There's information coming in from our eyes because we generally see what we before we put it in our mouth. And all of that information, that's just beeps and clicks and whistles hitting our nervous system. Okay. And our brain, we have to make sense of what it is. So we're always one step removed from reality. And I know that can sound a bit nebulous, almost like just because you can see and hear me doesn't mean I'm actually here, for example. But go with me on this train of thought for a few minutes, if you will indulge this idea. And the first kind of lesson I want us to go through in this idea is that we're prediction machines. Okay, so if I show this image on the left, for most people, it'll be unintelligible. They'll see it as, like the Rorschach test that they give the Joker and Batman, images of ink blots that all look like butterflies, for example. So people won't be able to make sense of this mostly. But if I show you what the original image is and you scan your eyes back and forth across them, then the features of this blob image, if you will, this high contrast image, should become much more clear. And you may well be able to see, the brim of the hat. You might be able to see the front of the lady kissing the nose of the horse, for example. You might be able to see the horse's bridle. Some of those features may become more clear. And the reason that is we don't sit here waiting for sensory information to hit us. In fact, we're prediction machines. So our system, and this is not a conscious thing, this is not an unconscious control thing. Our nervous system is constantly trying to predict what sensory information is coming in, what's going to come next, so that we can make sense of what's going on in the world. So this is an example of it, because at first, this first image I showed isn't that intelligible. Then you see the new image, you now have information on which to base your predictions, and the other image becomes clearer. So I've shown this with vision. Let's show it with some other senses. So I'm going to play what's called a sine wave speech file. And a sine wave speech file is basically, it's going to be someone talking, but what we've done is we've degraded the human qualities. We've taken the higher pitches out of it. So when you hear this, it's probably going to sound more like R2-D2 than a person. But then I'm going to play the original sound file. So now you'll have heard it as a real person. And then I'll play the sine wave speech file again and see, it won't sound like a human. See if it is more intelligible, if you can suddenly hear what the person is saying. And I've played around and given lectures on this and played around with this concept so much and played around with these files so much. They actually kind of feel human to me at this point. Okay, so let's see if it works for you. So it shouldn't really sound too intelligible. I'll try it again. Now I'll play the real sound file.
She cut with her knife.
And I'll play the sine wave speech file again. And so for many of you, that may become more intelligible. It may become more intelligible. And so that's because you have something on which to base your predictions. So let's show now, as I mentioned earlier, when you eat things, you're integrating multiple senses. It's not just what comes from your mouth, because you're integrating what comes from your nose, you're integrating what you see with your eyes, etc. So let's have a look and see if we can play with this concept across modes of senses. So I'm going to play a sine wave speech file, but then I'm going to just show you what the words are on screen. You're not going to hear them in their true sense. And I'll play the sine wave speech file again. And if you say those words in rhythm and in time to the sign wave speech file, can you suddenly hear what it's saying properly? I'll try it again. Most people don't pick that one up first time. It may well be that now when you've got something on which to base your prediction, that sound file makes more sense. And we know this. I mean, food and food marketers for a long time have known a lot about predictions. So, for example, if you give people brown M&Ms and green M&Ms, people will rate the chocolatiness of brown M&Ms being higher. Like they've got more cocoa, they're more intense chocolatiness, even though they're exactly the same. And if you tell people, you change the labels and you get a pack of M&Ms and then you change them, put them into a new bag with a new label that says these are dark chocolate, handmade from some artisanal market somewhere with a homemade recipe that's 300 years old. You know the idea that you make it seem fancy and sound fancy, and etc. Suddenly people will rate those same chocolates as being much more chocolatey when they taste them. And of course, then if you combine the idea of color and label, you get a more pronounced effect. And what I'm trying to say here is, even though they all probably taste the same, because of information from our eyes, predictions we make about our eyes, or information we are told about the label, that changes what we actually experience. And in a wonderful, I'm not so sure if there's any literature fans listening to this, but I always think of this, the book Great Expectations. I always think of this as grape expectations. But there was a wonderful study about 20 years ago where they brought some white wine out to a bunch of people who, the type of people who kind of enjoy wine and smell wine, and they say, I can smell this and I can smell that. I'm not so good with wine. It just all tastes the same to me, unfortunately. But they brought this white wine out to these people, and they stuck their noses in it and had a smell, and they said, "Oh, I smell watermelon, or I smell melon and citrus and straw," and the type of descriptors that would be common for white wine. And then they took the tray of white wine away, and they put in a completely flavorless and odorless red dye into the same wine glasses, brought them back out. The people swilled them, put their nose into them again. I smell roses and chocolate and cherries, and you're the type of descriptors that fit with a red wine, right? And so the key thing here is what they're seeing with their eyes is changing what they're experiencing. So the prior information they have is altering the predictions. Okay. So why does all of this matter? Well, the first key point I want us to get is, firstly, we never experience the world or what's happening inside our bodies as they actually are. Okay? We never experience this as they actually are. Rather, we actively create and we shape a percept that is a balance between the incoming sensory evidence within our system and predictions based on information already held in our system. Now, I just need to be very clear, these predictions are not, it's not a conscious thing largely. This is just how your nervous system operates at kind of super fast nervous system speeds. It's not really a conscious thing. Let me give you another example of this, and I'm going to play you a video of one of my favorite comedians, Peter Kay. He's got a strong British accent, so I hope, and a North England accent, really, and so hopefully that's intelligible to your ears. But I want you to just sit back for a minute and have a watch of this video clip and see if he tricks you into hearing what he wants you to hear.
You all know about karaoke. When you're singing on a karaoke, you haven't got a clue that those were words. I was singing Take That, Back for Good. Wash your back, wash your back, wash your back. Want your back? What's this? Want your back? I've been singing Wash Your Back 15 years. It's only when you go on a karaoke and you see lyrics, that's what they're supposed to be singing. You know that song, We Are Family? For years I thought they were singing, Just Let Me Staple the Vicar. Right? Who's right and who's wrong here? Listen.
All of the people
the vicar. What's all that about?
Just let me staple the vicar.
Okay, so I suspect most of you heard as a lyric, just let me staple the vicar. And you know it's a joke. You know you're being conned. You know that that's not a plausible lyric. But yet, unless, of course, you listen to that song every morning in the shower, for example, unless, you know, you're going to end up hearing largely what he wants you to hear. I'll give you another example. I'll give you another example in a moment. But the key point here is that our system is always making decisions between prior information that we have in our system and the incoming sensory evidence. And what we experience in taste, sound, vision, I've given you examples of these, but pain as well. What we experience in terms of pain is always, it's always a function of the interaction between those top-down predictions and sensory information. And at different times, they will have different amounts of priority to sway what we experience. But imagine, you know, the most universally painful experience in the world for me with young kids at home right now is walking down the stairs in the morning in the dark and stepping on a piece of Lego. I'm sure we've all done it. It's it's no fun, but it feels different if my football team won or lost the night before. It feels different if I know I'm going to have a busy day in work or night. It feels different if I had more or less sleep the night before, right? And so what we experience in terms of any conscious experience, but pain, is not a direct readout of what's happening in our tissues. It is always influenced by these top-down predictions. And again, I emphasize predictions are not a conscious thing. So I'll give you another example.
If you listen closely, they're actually singing about pork pie. Pork pie, what's it got? Thinking nothing's wrong.
So I'm not sure if you got pork pied there, but I'm pretty confident the Cars, they weren't singing about pork pie in that song. But nonetheless, he has led us to experience what he wanted us to experience. And so the key thing here is we have multiple, our system, our nervous system has multiple hypotheses, okay, multiple models, multiple answers to what we're actually experiencing. And as a general rule, we will pick the one that's least surprising. And so he has fed us with information in advance. He said pork pie. And so that's primed in our mind. And when we see him move his mouth and we hear the sounds, we select, not consciously, but our system selects the kind of easiest, least surprising model, the most energy efficient model, if you will. And that's what we experience. So consider this for a moment. As I said, I'm at a stage of life. Yeah, my daughter turns 5 tomorrow, and that should tell you that my weekends don't much look like this over here on the left anymore. But imagine you're at a concert or a loud restaurant or a bar or whatever else, and your friend is talking to you and you can't hear them. So what is it that you do to understand what they're actually saying? Well, you might lean in closer. You might turn your head so your ear is closer to their mouth where the sound's coming from. But you may also hear with your eyes. So you'll focus your eyes onto the shape of their mouth. And so that's how you know if they're asking, do you want a drink? Because you know what that shape sounds like, or you know what that shape looks like. And so the point I'm trying to make here is, again, I mentioned earlier, but it's the integration of multiple senses. So your system may switch, right? May switch lanes, and suddenly you're using other senses to hear. And so there are two key points I want to make here is that one, there's always competition between different forms of sensory information in our nervous system. Okay. So in this case, vision and sound, always competition. And two, you actively use your body to change and shape the sensory information. Here it's averting your eyes or getting closer or turning your head, for example. But you use your body. Your body can be used, we call this action. You can act to change the sensory information and the competition of sensory information in your nervous system. I'll make this clear what this means for pain in a moment. So this might sound very long-winded, very kind of scientific. Perception and action are inextricably linked, whereby we predict a given set of sensory inputs and we act in order to confirm or generate the expected sensory consequences. Okay, that mouthful kind of summarizes everything we've done so far. So let me say this. We predict sensory information and we use our body to change and shape that sensory information to conform to the predictions in our system. And in doing so, we actively, but not consciously, but we are active participants in creating our reality and what we experience. And you saw, you heard his false lyrics. And you heard them because he planted prior information beforehand that you could make predictions on. And you used your eyes to look at his mouth and you saw the shapes of the mouth and they confirmed what he had said earlier. So that's what you heard. So why does this idea of competition between the sensory system really matter? Well, it really matters when it comes to pain. And in fact, I was actually teaching my undergrads about this yesterday. I remember for years and years and years, I used to read these studies, and I've been around some people who've done some of these studies where they'd get a bunch of people with back pain or knee pain, knee OA, whatever it might be, and they test how their sensory system works, and they compare that to people who don't have long-standing pain, and they'd find things like, if people have pain, you can move them much more passively, like you can move them much more before they'll detect that they've actually moved. Okay, so they've got a larger movement detection threshold. Or you have to press on them more firmly before they actually recognize that they've been pressed on. Or their posture will move and change more than people who don't have pain before they can actually detect it. Or if you press on them in two different positions, they kind of will feel that as though they're only being pressed in one place. Or if you press on them, they can detect, yeah, I can feel you pressed on me, but I'm not so sure. Was it above or below my elbow? I'm not so sure on that. The whole idea here is there's lots of change in their nervous system. And then equally, we do some experiments, and I've done several of these where we put probes on people and we heat the probe up and get them to tell us where these at first become painful. And that threshold from heat to pain is much lower in people who've had pain for a long time. Same thing with electrical stimulation, same thing with pressure. The idea being that they are more sensitive. And I remember thinking, same with cold, for example, I remember thinking, well, okay, why does this matter? And it was a conversation with one of my colleagues about 10 years ago, Ben Wand, who's done a lot of work in this space, where he said, well, it's easy, don't you see? And of course, I said, well, no, I don't see. He said, look, their nervous system is very, very good at detecting what we'll call noxious information, the nasty stuff that might pertain to damage or threat or injury or inflammation, for example. System is really, really primed to detect that. And not so good at detecting the non-noxious information, stuff relating to touch and movement, but it's not about threat and damage. And if we go back to what I mentioned a minute ago about competition in the nervous system, that means that at all times, this noxious information, or a lot of the time, is likely to drown out competing non-noxious information in your sensory system. And so the final point of all of this section is that people who are in pain, they downweigh non-noxious information. So think about it, their nervous system has turned the volume down. This is not a conscious thing, but it's turned the volume down on how it processes information that's not relating to threat or damage or danger, and turn the volume up on information that's related to danger and threat and damage, which can mean that you can have a lot of pain, even if the damage is largely healed, or even if the damage is healed. Or you can have a flare up in pain without doing more damage, because it's just that the system is turned the volume up on the processing of that sensory information. This is our thinking. So let's go on to the idea of what's changed in terms of treatments because of this line of thinking, or in parallel with this line of thinking, I should say. And I mentioned before, this is a very exciting time for people like me who work in the back pain world. It's a very exciting time because 2 years ago, if someone had said to me, have we any really effective treatments that help the types of patients I mentioned at the start of this, people who've had pain for a long time and are really struggling to get better, to help those patients, have we any really effective treatments where there's really good evidence that is effective at reducing their pain and reducing their disability in a meaningful way? So there's a big change, and that it's sustained over time. And these studies have been done, with high scientific rigor, etc. And if you'd asked me that 2 years ago, I'd have to say no. I don't think there are. But so in the last 2 years, there have been 3 large studies on 3 different forms of treatments which have shown sustained and large treatment effects on pain and or disability for people with low back pain and the types of patients who are unlikely to just get better on their own. So that's really exciting. I'm going to focus on one of them. And the reason I'm going to focus on one of them is, I'll declare my bias. It's a number of my friends and colleagues who have developed and tested this. So that is one part of it. But the reason I'm focusing on it, I think it's the most scientifically rigorous of all the studies. Okay. So I actually think it's the best, as far as I'm concerned, it's the best one because it's the most and best tested, if you will. So if we take everything that I've said about pain and conscious experiences, and I mentioned earlier the idea that there's multiple interacting domains that are relevant to pain, not just your thoughts in your head and not just what's happening in your tissues, but it's an integration of everything about you and how your nervous system operates and all of the sensory information within and around you. There's an argument when it comes to pain, and we call this the fit for purpose model, that we need to try and help people who are in pain it's important that they understand that it's safe and helpful to move. And what I mean by that is if you've had a scan and you've been told this is the worst scan I've ever seen and your spine is crumbling and you're going to end up in a wheelchair and those types of things, well, that's not helpful. You have to consider what types of predictions or how that might inform the predictions that your nervous system makes. If your understanding of what's going on is that you're broken, that you're not safe, that you're crumbling, that you're never getting better. So we're saying there is a cognitive and behavioral aspect to understanding pain, but also treating it. We need people to understand that they can move and it's safe to move and it will be helpful to move. Now, of course, if you've had pain for 30 years, someone just saying that to you, it's unlikely to really resonate. So we need to experience that it's actually safe to move, and we'll come to that part. The second here is feel that it's safe to move. That's not about emotional feeling or a cognitive feeling. It's a perceptual idea. Remember I said people in pain, they process sensory information, they feel things differently in terms of sensation. And so we need to make changes to how their system deals with different forms of sensory information and how it processes that competition between non-noxious sensory information and noxious sensory information. Effectively try and turn the volume down on how the system processes information, the nervous system related to threat and damage, and turn up the competing non-noxious sensory information. And so this is really exciting because I suspect most people, if you've had back pain or whatever, you may have done some exercise with the physical therapist. They may have done some manipulation or massage or acupuncture or dry needling, but not necessarily explored and played with this idea of how processing of sensory information. And this is one of the major breakthroughs that's happened in the last couple of years. As I said, people need to learn and they need to understand cognitively and behaviorally. They need to have changes in their perceptual system. And that happens through experiential learning. And so we embark upon a series of cognitive, behavioral, and perceptual experiments to shift the way the system operates. So telling someone about this, telling people that you can have a flare up even if the damage isn't increased just because you've your system has become more sensitive, that kind of noxious sensory information, that's all well and good, but having the person experience through experimenting that they can move and it's safe to move and it's helpful to move, that's what really shifts the predictions in the system, we think. And then finally, we think exercise and movement is a really important thing, and it's a way of reinforcing this new understanding, this new perception, this new experience of what it feels like to move, and that's reinforced through repeatedly exploring exercise and movement. Okay, so that's the kind of model, that's the framework. Let's look at the evidence. So this was published in JAMA 2 years ago by some friends and colleagues of mine, and I'll declare I wasn't part of this study. I'm just simply not clever enough. But this was done by people I'm very happy to call friends and colleagues. And so they got about 270 men and women over in Sydney, Australia, and they had pain for at least 3 months. But in reality, they on average had pain for many, many years. And so these were the types of patients I showed on the graph earlier that kind of our traditional treatments have not been that effective at helping. And they were split into two groups. One group embarked upon what we call graded sensory motor retraining. That's the treatment of interest here. Graded sensory motor retraining. And the name says it all. It's graded, so it's progressive. Sensory motor, we're training how you move, but also how your sensory system processes information. Okay, they embarked upon that. And the control group, that was compared to a group of patients who got a truly credible and believable sham treatment. And this is what's so important here. In order to see if a treatment is really effective and has merit above and beyond like just a placebo and the fact that you're in a study and people are being kind and nice to you, for example, to see if a treatment really is better, you have to compare it to a truly credible sham. And so what's novel about this study is the treatment is novel, but also in terms of methodology, they developed a truly credible and believable sham treatment. And they looked at people's pain at 18 weeks and then followed them up over a year. This big kind of Gantt chart, if you will, is just outlining the treatment. So just let me walk you through this for a minute. So it took place over 12 weeks, or they did 12 treatment sessions, but it took place over 18 weeks because, some people might go on holidays for 2 weeks in the middle of it, or they might be sick and have to take a week off. So they did 12 treatment sessions or 12 weeks of treatment, but spaced over 18 weeks. And in their first session, they had a chat about pain and about the inferred nature of consciousness and some of the concepts that we've spoken about. They just wanted people to understand, look, we think your tissue damage, we think your pain in your back, we think what the inflammation from your back, the injury, it's real, but it's not everything in this equation. Okay, so that was really important. Then I showed you the images, left, right recognition. I showed you pictures of feet earlier, right? Well, they did this with the back. They started the people in week 2, looking at images of people twisting and turning to their left or to the right side of their back and distinguishing, was it left or was it right side that person was moving to. Then I've mentioned people are less good at determining where they've been touched. By week 3, they're starting to do some tasks where the person has their eyes closed and they're being touched at various parts of their body and they're trying to isolate and say, yes, where have I been touched? This was in the back, of course, but the concept is holds elsewhere. By week 4, they're starting to include this idea of motor imagery. So people imagining doing movements, kind of bringing up the idea of movements in their mind, even at first watching other people doing movements that they struggle to do rather than doing them themselves. But again, you think about preparing, lighting up the areas of the brain associated with doing those movements, but without actually stressing the body itself. all the way up to, by the time you get to week 6, then they're starting to go into movement and what we call precision focused and feedback enriched movements. So lots of small movements, precise movements done with lots and lots of visual and tactile feedback. So touch and vision and sight telling you how to move, etc. All the way up to, by the end, they're moving on to kind of an exercise program. So this is what it looked like. Okay. In the next slide, I'm going to show you that compared to what the control group got. So this is the same image I just showed you, just a smaller version. But the control group got the same amount of time with the practitioners, the same amount of attention, and they were given a whole load of different types of treatments that they believed were real. So this is really important. The people in Group B, they thought they were getting a really good whiz-bang fancy new treatment. They believed it. They tested. People couldn't tell, am I getting the real treatment or the fake treatment? They didn't know. And so that's really important in this from a scientific point of view, because if people believe a treatment will work for them, they will have an enhanced treatment effect. And so if you can outperform a treatment that they think is active and believe will work with them, then there's real merit in the treatment that you've used. And that's exactly what happened. So we saw they should say, saw a substantial reduction in pain between the two groups. It might be best demonstrated visually here. And so the blue box is the pain score. So we're talking average pain when people starting the study in both groups was about a 6 out of 10. So a reasonable amount of pain. Some people had higher pain, of course, some people lower, but on average around a 6 out of 10. But by the end of the study, the average pain is about 2.5 out of 10, right? So that's a huge drop in pain. And then when it comes to disability, these people were reasonably disabled by their pain, but by the end of it, the average disability score is about 1, meaning these people are doing extremely well. I'll note, of course, you can see there are some people here for whom the treatment just did not seem to work for, and I know that group are trying to figure out why is it that in 10% of these people it just didn't shift for them at all. Okay. But this is a result unlike we've ever seen. And so it gives, for me as a clinician, for me as a researcher, great hope that we can help people, and hopefully for patients who experience this kind of non-specific pain. So I'm saying pain that's not of a very sinister reason that needs to be cut out of you or needs to be on very specialized medications, et cetera, et cetera. Should give hope that we can actually start finally turning the corner, and there are treatments that may well give long-lasting and sustained and meaningful benefits without being overly invasive, right? So what you got to remember here is this isn't drugs with like high side effects, and this isn't, a surgery where they're, fusing discs together or whatever else. So the side effects of this is very low. The really only downside, of course, was if the people in the study don't have to pay for that treatment, people would have to pay to see a physical therapist or a chiropractor or whomever who could administer this treatment. So there's a cost to it, of course, but the in terms of healthcare downsides would be extraordinarily low. So if I have to summarize everything we've done for the last little while, I'd say just to consider the idea that even if your back is really sore, and providing it's been ruled out that it's not of a very sinister cause like a tumor there or a fracture there or something quite sinister, then thankfully lots of people and most people get better rather quickly, and that's a good thing. There's a proportion of people who don't, and that pain lingers and it hangs around. It becomes chronic or persistent. They're the words we use, and that's a real problem for them. But we believe that pain is not just about damage in their tissues, and so treatments that are just based on trying to fix some kind of issue in the tissues have traditionally not been very effective for people. They might provide some short-term relief, but don't give meaningful outcomes. But we started to consider the wider operation of how our nervous system integrates different sensory streams, integrates predictions as well as incoming sensory information, and the competition between those sources. And developing treatments that kind of align with that perspective has started to show real and true promise. And for the first time, we think there are treatments that may be of real benefit to a lot of people. And in the immortal words of Forrest Gump, that's all I have to say about that.
Thank you. Oh my goodness. That was amazing. We had one question about hypnotherapy. Do you know anything about hypnotherapy and pain management or relief?
Yeah, okay, that's a great question. So it's one of those things that if you look at the studies, I don't think it's especially well studied, and I don't think the treatment effects are near as impressive as what we see in this study I've just shown. Having said that, I have unquestionably seen patients who said they've embarked on it and really found it beneficial. And so, you know, my feeling with that is, again, it's a reasonably low cost, reasonably low side effect treatment to try. If someone has had pain for a long time and they try it and they get some benefit, fantastic. I will say this, it's not because one of the things about hypnotherapy, right? It's not, what I'm saying is that the treatment that I've just suggested is kind of top down and bottom up, right? So it's like information from the tissues and, you know, top down information from within our brain, not conscious, but that's fine. And hypnotherapy, of course, is very top down. And there is another treatment, one of the three treatments that I said has been tested. It's not hypnotherapy, but it includes it's extraordinarily top down. So it includes elements of real mindfulness and almost meditatively sitting with your pain and trying to understand and kind of be with it and understand that it's not about damage, and testing it in various different ways. And it's called pain reprocessing therapy. And that is one of the three studies. It's not tested quite as rigorously as the one I've shown, so that's why I've not shown it. But that's one that's worth exploring. And so, because it's probably one that leans closer to hypnotherapy and certainly has a much more impressive outcome in the study than any hypnotherapy study I've ever seen. So to summarize, I would have no problem that people try it, of course. I don't think the evidence is fantastic. There is one treatment that has better evidence called pain reprocessing therapy that does very much align with it. And I've unquestionably seen patients who found kind of hypnotherapy very effective. And I've seen patients who've said, look, it wasn't for me. But I'm kind of all for, if you've had pain for a long time and you're trying to try things that are of benefit, I would try things like that aren't, surgery that are, you get an infection and it's a problem, or it's a drug that has terrible side effects. Hypnotherapy doesn't seem to have enormous downsides. You try it, it works for you, fantastic. You try it, it doesn't work for you, well, you haven't lost much, right? But for the person who's exploring that idea, and I don't know if they're a practitioner, I don't know if they're a patient, but if they're exploring the idea, if you're looking at very kind of top-down therapies like that, pain reprocessing therapy is probably the one with the greatest promise. And that is from a bunch of American researchers. Actually, I think they're in Colorado.
This is an interesting conversation. The last seminar we had was on gaslighting, and frequently people are told that it is in their head, or often in the case of anal cancer, the symptoms are minimized, but it's a similar thought. I think that what you've talked about in terms of quality of life and the things that people who have been through anal cancer treatment, or even there's a seminar coming up about pain during high resolution anoscopy. I find it interesting that we perhaps can look at our pain in a different way, and figure out how what our expectations are, because
Yeah. Well, there's a
that's
few.
go ahead.
Sorry, Margie, go ahead. I think I spoke across you because there was a delay there. Go ahead.
No. So I find this thing about the expectations to be really interesting. I mean, when you go through this treatment, there's acute pain during the treatment, and some people have pain for a long time afterwards, and many different kinds of pain. Pelvic pain, GI distress, just various things. So I hope somebody looks at the kinds of pain that people who go through this kind of cancer treatment and studies it, because many of us feel kind of abandoned by the
Yeah.
medical system, and I love the medical system, but sometimes we just have this sense of I just have to put up with this.
Yeah. Yeah. I mean, and look, it's what you say is so true, Mary Jo. In my world, in the back pain world, I can't tell you how many patients I see who go, well, I was told my pain's in my head because my x-ray is normal or my scan is normal, meaning my pain is in my head. And like it's such an unfair position to
Mhm.
put someone in and to state because if someone has pain, it's real.
Mhm.
If someone reports pain, that is their content, that's what they're having. It's not in their head, it is real.
Yes.
They're not choosing to have it. They're not malingering. It's real. And it's our obligation to try and find a solution to that. And of course, so cancer pain, of course, is different from the kind of non-specific low back pain that I've spoken about here. And I'm by no means an expert in cancer pain, but it's just so incredibly unhelpful that anyone is made to feel like their pain is in their head and they're invalidated in that way. It's kind of the opposite of healthcare. The word care is there, and so we should emphasize that. I think there's a lot of areas of medicine where, for so many ways, I know some colleagues of mine who work in burns, for example, so people who've had major burns from fires and things like that, where all the focus and research and healthcare for so many years was all about just, can we learn how to keep these people alive? And so they've gotten much better at that. Okay, can we learn how to get them out of can we learn how to get them out of hospital quickly and back home? Okay, cool. But they've ignored the fact that, okay, with survival of, like, from burns, there is enormous amounts of pain and other things. And it's only now they're going, okay, people are living with this and we need to take this seriously.
Yeah.
So, I hear you. I hear you.
Somebody is asking how to access the treatment you're discussing, and of course, it feels as if you're a bit on the cutting edge of this, which is part of why I asked you to come and speak to us.
Yeah. Look, it's a great question. Of course, unfortunately, you hear these terms and these adages. It takes 17 years on average for medical findings to make their way into kind of normal clinical practice. I'm not so sure it takes that long these days when we have the internet and Zoom and all of those things, and an international conference. I don't know if it takes that long anymore. But to answer that is, there are increasingly kind of probably physiotherapists and chiropractors and other healthcare practitioners who would be becoming familiar with how to do this treatment. It's I agree, it is new, but what I would say is the information is out there, and if you have someone you're seeing and they don't know how to do it, they could always read the papers and learn how to do it a little bit as well. And so I think the key thing would be to ask, I'd be asking, your physio or physical therapist, or if they don't do it, asking someone else, do they do graded sensory motor retraining? Do they know anything about it? If they don't, tell them they should. And if they do it, fantastic. But you're right, like this is new. So the studies on it have only been published in the last kind of 18 months or so. So true infiltration hasn't fully happened. Like, my students going through the uni, they learn all about this now. So there are graduates out there doing it. We're in part of the world we're from. All these things take time to filter out. But I think, if you nudge them to get up to date on it, I think.
So in this, another topic that it has empowered us a bit to at least ask the right questions.
Yeah, well, you've got to be your own advocate. In healthcare, you always have to advocate for yourself. And so, I would be very, if one is seeing a physical therapist or a chiro, so it would be a treatment that would be largely administered by physiotherapists or physical therapists and chiros and osteopaths. It'd probably be the three. And I'd be not, I'd be forward in asking, hey, do you know about this? Have you tried this? Because it's not, most physios would already have the skill set to do it. They just wouldn't know how to package all up together into a coherent process. But we've now done that, and it's there for them to be able to do it, right? So yeah, I would. There are training courses and books and websites and everything for training them in the pipeline. I'm aware. I'm not part of that aspect of things, but I know that's there. But I know they're also not live yet. So, but I think if you nudge people, they should be able to resource themselves.
Well, thank you. We have gone way over what we normally do. I always say that I finish on time, but
I apologize.
but no, it's okay. You're Irish, and
Yeah, we
Irish.
live on Irish time.
But I wanted to thank you. I also wanted to wish you a happy Anal Cancer Awareness Day, because it's the 21st in Australia, and we will be celebrating, or at least acknowledging, that tomorrow. And
Okay.
and there's going to be, the Anal Cancer Foundation is having a seminar that you can sign up for. It starts at 12 Eastern time. What else did I want to say? I also wanted to say that this will be recorded, so that because of the strange times, people can listen to it later. And we also recorded all our other seminars, and you can get to them through the website. And we also have a podcast. So all of those are available through the IANS website. And let's see, I had one more. Audra, could you put up the slide for what you've talked about, Merv, is quality of life. And we're doing a UCLA professor who's part of IANS is doing a quality of life study. And so if any of you have patients who have been diagnosed with anal cancer and gone through treatment, you can click on the QR code and fill out the survey. The more we get, the better. And Nigel, I'm sorry, I just called you your brother's name, Merv.
Yeah.
You might find it interesting what we find out in terms of what kinds of things people live with
Yeah.
immediately post treatment, and then years and years and years down the road.
Yeah, absolutely.
Okay, you can take this slide down now. Thanks, Audra. So thank you so much. I hope you'll come back, and as you learn more things, and we perhaps have more questions that will come your way. Just a new message. Hang on if I missed something.
Yeah, no problem. And I've just popped the reference like for that study. If people just take that and put
Oh,
that into
that's
a
good.
Google browser, they'll get that paper. It's open access in JAMA, so it's there. So you can walk into your physical therapist and go, "Hey, do you know about this? Because read it and be
That's
your own,
perfect. Yeah.
yeah,
So that's
be your own advocate." And
in,
as I declare, like this is for, like, if you will, musculoskeletal pain, kind of chronic, non-specific, so not caused by fracture, not caused by a tumor,
right.
but it's not specific. Like they studied it in the back because they need to do it. There's no reason why it wouldn't apply to the knee or the elbow or the shoulder or whatever.
Or the pelvis, or
Yeah,
the
exactly.
you know.
Yeah, or the pelvis. And well, actually, there's work in the pelvis ongoing right now with it.
Okay, well, we'd like to hear about that too.
Yeah, indeed.
Okay, all right. Thank you so much, and thank you for everyone who's attended. And I hope we get to talk again, and say hi to your brother. I'm
Will
sorry you
do.
didn't get to come.
Yeah, no problem at
Okay,
all. Thank
all
you
right.
so much. Thank you for the invitation, and I wish everyone well. And of course, that makes tomorrow a very important day.
Yes. Okay. Thank you.
Bye.
Bye.